Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and I am going to take you through another exciting left main bifurcation case. Samir, good morning. I am sure the viewers have seen the new, very interesting and exciting opening for the program.
Very good, very good. Welcome to our now the 7th year. The
7th year starts this morning. You're absolutely right.
So it's episode 73, and really thank all our viewers who periodically, any meeting we go, the one thing they all come up and say that how has been this wonderful teaching, and of course majority of them go to the archived cases rather than be on live. That's okay, be it as may, as long as we are helping people to learn these complex interventions and of course providing that didactic discussion which has been the focus of our this monthly webcast.
Well, not only that, they can now go to the website and the app and stream it and go back and review it later. Samin, happy with your conference?
Yes, it was super, very good. First time we went out of Mount Sinai, but we're coming back to Sinai again starting next year. But I think knowing that we do a monthly webcast of the CCC cases, then we have endovascular, then we have every other month structural. We keep it one day for us next year also. So we'll just keep it one day, but the day may change. Not may change, we have decided it will be Thursday. And one thing which was very much lacking and which was very prominent, and everybody had that feedback, that since we started our CCC Live Symposium, our boat cruise was a really mingling place and relaxing. So that will come back next year.
Excellent. And the symposium archives are all available,
yes,
and you can download from the iPhone app.
Perfect. So with that note, we start for this morning. Our supporters right here, the disclosures which has nothing changed. This is a 79-year-old male who had hepatitis, cirrhosis, prior PCI of the RCA, presented with new onset class 3 angina and dyspnea. He has a very interesting, which we see many times, patient with the left main disease, that negative ischemia on perfusion imaging, but positive ETT, that exactly he had. And then he had a left main and other vessel disease, which will show. The discussion took place, question about surgery versus intervention, and patient basically because of actually in this case, the preference of the referring physician was surgery because of the left main, will show you, but they felt surgeons, because of cirrhosis, that PCI is a better approach. You want to show what we have?
So this is the LV gram, which was a normal LV function, and we have his prior RCA stent, patent. RCA was non-obstructive, and this is his left main. So distal left main tapering to about 50%, but more interesting is involving both the ostial LAD, ostial circ, again 50 to 60%, and rest of the circumflex as well as LAD is non-obstructive.
Yeah, very severe
bifurcating distal left main, which you can actually see better in the cranial view, involving both the ostial LAD and ostial circumflex.
Okay, so with that note, the syntax score is 26, and that is the plan today. Do the IVUS also, and then guide us in terms of our intervention. People always ask that how much IVUS you do in your left main cases. I would say probably about 10-15%. So we don't routinely use, although there are data to support from the left main registry data, that IVUS may improve overall survival and outcome of these patients. But yes, if there is a question, we will do IVUS. But more importantly, if there is an angiographic calcium, we will do atherectomy, whether orbital or rotational. That is the key.
So is the IVUS number low because you are doing more OCT also?
Well, IVUS number actually is low now because it's a very little part it plays in the plaque or angiographic detection, the obstruction detection, which we used to do with the lumen cross-sectional area of 4 mm square, except in the instant restenosis. Now that has been completely replaced by FFR. So we guide our therapy based on the FFR and not by the IVUS anymore. And that's why the IVUS numbers are down. OCT still remain, as Anu will, the master of OCT will comment that how OCT is done in our Cath lab.
Oh yeah, I mean at this time it's basically most of the time for imaging purposes is in our research protocol that we are using OCT, and rare situation if you have to understand plaque morphology, especially if some patients have come with ACS, rare patients with instant restenosis, we have been doing OCT for understanding the plaque, not to guide the therapy since it has not made to the guidelines yet. So if you have a intermediate lesion with no ischemia, mild ischemia, and you have to guide your therapy, it still has to be FFR, not any kind of imaging.
Yep. Okay. So with that note, now as I said, appropriateness just because the ostial LAD and ostial circ, but more importantly, if you take the American and European guidelines, as you can see here, CABG, everything is class 1 for European and American College of Cardiology. For the PCI, we actually have the patients with the isolated left main disease. The key is your hard team approach, like in this particular case, that's a class 1. And then if you have simple lesion, then it becomes 2A, or patients who are high risk for surgery. And in our European or American guidelines, that if patient has a high syntax score and multivessel CAD along with left main is class 3B, particularly those who are low surgical risk. So in this particular case will fit in that we have a hard team approach, and this patient has a 2-vessel disease with syntax score of less than 33, so will be appropriate. So now what we will do, Anu will get ready and do the IVUS, and meanwhile I'll go through our topics. Later. Okay, let's see after the first point, we go with our topics, and then of course after the first discussion which Anu is going to lead of the Peri-procedural MI, then we will continue the second part of the discussion of the recent trials of the newer DES versus CABG in multivessel CAD, and then we do the IVUS. Now basically, just to talk about what is Peri-procedural MI, or we call PMI. It occurs in 5 to 40% of cases. It could be macro size due to dissection, side branch closure, and so, or micro size due to distal embolization, microvascular plugging, slow flow and spasm. So that to me, macro size with the newer techniques is very rare. That may occur maybe 1% of cases, but other your 4, 5 to 8% of cases occurs because of distal embolization and microvascular plugging, and of course many of them are platelet mediated, so that every study of the potent antiplatelet therapy, be it prasugrel or ticagrelor, has shown to be beneficial over clopidogrel because of better platelet inhibition and lower periprocedural MI. Second, various definitions are available at present, but the most common one is the universal definition, which is type 4A of the periprocedural MI, that is troponin more than 5 times of 99th percentile of upper reference limit. So basically 5 times, or because the SKY said, you know what, this happens in many cases, let's go where really it makes a difference, and SKY definition of PMI is the CKMB more than 10 times or troponin more than 70 times of upper limit of normal. Now also it's supposed to be associated with chest pain, EKG changes, angiographic complications and myocardial loss and imaging, whether it's IVUS, on the echo or on your nuclear stress test or thallium, whatever it is, or MRI, but usually we don't talk about that. Purely when we talk about MI, it is directly related with your troponin or CKMB elevation. Then third point, the PMIs are associated with increased future cardiovascular mortality. Even at a small level, there is some controversy that what is that level. Some people say 3 times, some people say 5 times, but to me I think the 3 times, less than 3 times probably does not associate with the cardiovascular mortality, although there are some data to refute it, but overall future cardiovascular mortality goes up once you have a periprocedural MI. So therefore, various approaches are used to reduce periprocedural MI. One is pre-treatment with a strong potent oral antiplatelet therapy, whether it used to be upstream use of the clopidogrel in earlier trial, PCI cure and so, or now with the latest agent of ticagrelor and prasugrel, or high dose statins by various trials including Armida have shown to decrease periprocedural MI, then 2B3A inhibitor, distal protection devices particularly in patients with acute in the vein graft issues, preconditioning, you are inflating your cuff and really has shown, and beta blocker, which we have our paper that patients on beta blockers have lower periprocedural MI. So therefore, we need to decrease the periprocedural MI. Then question is, how do you, which case you can identify, besides doing a good intervention, most common cause or most important factor decreasing PMI is do a good intervention. You do not have those micro and macro issues, but clearly there are factors now which has evolved, and that has come to the limelight in last few months of papers, is that imaging parameters for periprocedural MI, that is attenuated plaque by grayscale intravascular ultrasound on IVUS, necrotic core by radiofrequency IVUS, which is virtual histology, which we learned from the Prospect trial, then thin cap fibroatheroma by OCT, or large lipid core plaque by near-red infrared spectroscopy NIRS. So, these are the one which has really have evolved in last few years, particularly last few months with the publications which has brought this field of imaging in predicting periprocedural MI. And this actually, the editorial with the two papers which we are going to discuss is that can multimodal imaging, invasive imaging be used to predict periprocedural myocardial infarction, and this is what Anu is going to discuss about these two studies which have just come up now.
So, I think just to reiterate what was just mentioned by Dr. Sharma, that periprocedural MI is still there, and the incidence, as you see, can go anywhere between 8%, 15%, used to be higher before, but has gone lower with the use of antiplatelet therapy, statin, as well as the newer stent. But everybody knows if there is a procedural event which is dissection or side branch closure, that you will have periprocedural MI. But what is important is many times, which is I would say about 10 to 15% of the time, there is no procedural event, but if for some reason a post procedure enzyme is checked, which is usually a troponin, you will see some troponin elevation. We know you need more than 3 times to have any outcome problem, but just presence of periprocedural MI has to be reported or should be followed after the procedure. In that case, the question was in initial this trial, which was a CANARY trial, to see is there anything that will predict to prevent this periprocedural MI. Previous studies by NIRS had shown that in stable patient, if you have done the NIRS, that if your LCBI was more than 600 in stable patient versus 500 in unstable patient, those patients followed by PCI, there was increased incidence of periprocedural MI. So, based on that, CANARY trial was designed that in stable patient you need to have negative troponin in these cases, and if you have done an LCBI and your LCBI was greater than 600, then you randomize the patients to filter versus no filter. The hypothesis was that you will see some kind of macro or micro embolization, that you will be able to retrieve it in the filter, and your incidence of periprocedural MI will go down. If you see here, just the number of cases that were enrolled was very small. 31. To say 31 cases were enrolled, just to show that the incidence of that high lipid core burden finding in proximal part of the vessel is very rare. So, that is one important finding that came from this trial, that it is very rare, and also that after randomization, which was a PCI plus filter, which was in red, and PCI alone, that there was no difference, that even if you have a high LCBI, presence of filter did not change the incidence of periprocedural MI in this particular trial. But if you see here, just the predictors were presence of maximum LCBI in patients with MI. Maximum LCBI was about 480 compared to patients with no MI, and lower cross sectional area, and more important is plaque burden was higher, and which several studies have shown there, essentially telling you that you need a big plaque burden, that is a big plaque, and that plaque has to contain lipid, and if you have both of these, that there is incidence of periprocedural MI. Since the numbers were low, multivariate analysis was not predictable in this trial. So, as we have been doing several cases with the imaging, what we predicted was that there may be something else that is also responsible in this stable plaque to predict periprocedural MI, and one hypothesis was that the plaque will contain plaque burden, presence of lipid, and what actually happens to the cap, that does cap matter. And what to understand cap, one imaging modality that is needed was OCT, since OCT characterizes the cap, and what we went through our imaging database was consecutive. What we did was patient who had pre-stenting and post-stenting in stable patients who never had positive troponin before the procedure, about 110 patients we analyzed, who had both NIRS as well as OCT. So, NIRS would include IVUS as well as the lipid core burden, and then we have OCT was done. So, 2 imaging modalities were done in these patients. Angiographic findings and procedural were not different in this 110 cases. Next. But what we found was that in this patient, that your thin cap, when we define thin cap, was less than 65 micron cap thickness. The presence of thin cap was higher if your patients who had periprocedural MI. The incidence of 110 in 110 patients, about 8 patients did have this any kind of troponin elevation, and other thing was the same, cross sectional area was lower and plaque burden was higher. And if you see the LCBI, which you have more about 556 in patients who had positive troponin, and if you go with multivariate analysis, what we found that only one thing, if you have all 3 imaging modalities, that you have plaque burden, you have lipid core burden index, and you have cap thickness. If you have all 3 in multivariate analysis, only one thing that predicted was cap thickness, and that is why we can probably say that you may have a big plaque which is full of lipid, unless your cap is thick. When you are stenting and when you squeeze the plaque, unless your cap is thick, that particular plaque will probably not embolize distally. And if you take out OCT, what others will predict would be, the first one prediction was the lipid core burden index, again should be greater than anything about 400 450. If that is not there, then if you only have IVUS, maybe a big plaque burden would be a predictor, and this is was the most important part from this particular study. And this is just a case which you see there in a LAD, which is mid LAD. You see a what we call a napkin ring lesion and significant LCBI, but if you see the lipid arc was also significant on the IVUS, and other thing is the plaque burden. So, everything was significant, but more important was the presence of thin cap was the one that predicted that this particular patient did have positive troponin.
And this is actually basically you said, yeah.
Yeah. So, what the editorial mentioned, that our study was the first one to demonstrate the superiority of OCT defined TICFA compared with other imaging modalities, that we actually showed that TICFA is the more important predictor if you have done multimodality imaging in this kind of stable patients to predict periprocedural MI.
Anu, congratulations for this very, very important study. Go ahead, complete what you were going to say first.
This actually is a slide from our yellow 1 trial, just to give you what is the incidence. It is very important to know what is the incidence of finding lipid in this stable patients. So, if you see here, actually if you take 1/4 of the patient, which is you see the red triangle is the patients who have lipid core burden more than 500. So, if you have high plaque burden, which is green, those patient incidence of finding high lipid in them is about 1/4 of the patients will have high lipid. And important is that you need to have high plaque burden and have high lipid core burden index to actually have this periprocedural MI. This is just a slide to show the incidence of what is the plaque burden as well as the lipid core burden index. You can take over now.
Now, you have any question for then we go to the next point?
Well, Sameen, I want to first of all congratulate Anu. You know, last time Usman Babar was there, and I told him that he was a prolific contributor because of 2 articles, and Anu now has 3. So, probably super prolific maybe is the right term, but very, very relevant studies and 2 great editorials following both of them.
Yes. Okay. Now we continue why they are engaging the left main and doing the IVUS.
So, there is a question has come because the EF is 60%, no need to consider any left ventricular support.
That is correct. So, that is exactly with our algorithm in this particular case, and it is not a complex. I would say if this case have a total RCA, even with a normal EF and distal left main bifurcation, of course, this kind of lesion with a heavily calcium, we are planning the rota, maybe put a balloon pump. But at this point, not a calcium, although IVUS may show differently, but angiographically not much calcium. RCA is patent, the good non-obstructive. So, unless there is some procedural complication, the pre-use, prophylactic use of the LV assist device, whether balloon pump or Impella, is not indicated.
And the next two questions are what imaging modality are you going to use, and if there is the role of FFR here.
Well, that is a very good point. So, that could be FFR, and second is the IVUS. So, that in this particular case with the left main, remember the left main even in the Excel trial. So, once you have the bifurcation left main, it is so tough to determine the role of the FFR. FFR is good for the proximal and body, but once you have the distal bifurcation, FFR was not favored. So, that is exactly what we will do. We were part of the Excel trial that this case will get the IVUS, and IVUS will do the cross sectional area of the lumen of the distal left main. If it is less than 5.5 millimeter square, that means it is significant, and this will be the we will show it online very quickly while I am going through the comparison of the newer DES and CABG in multi-vessel CAD. Remember, we had two trials of the Syntax and the Freedom, which were done with the first generation stent, comparing with the CABG, and of course showing that there was even higher mortality at long term follow up with these patients, and of course there was higher MI and lower CVA and higher revascularization, particularly patients who have a high Syntax score, clearly higher mortality with the PCI. Same thing, similar data we had in the Freedom trial, that with the PCI again 5% higher mortality at 5 years compared to CABG, again done with the first generation stent. So, question always comes, what about the newer stents, and particularly the everlumus eluting stent, which have been shown to have a very low stent thrombosis and also even lower myocardial infarction compared to the first generation stent, and of course lower TVR. So, this actually has been put to task by 3 studies, 3 publications again in last 3-4 months, and one of them, the lead article of in the NEJM, is the best trial from PARC in the 13 European center, which is the everlumus eluting stent versus CABG for multi-vessel CAD. This is the protocol design. They were supposed to do about 1800 cases, but then after 800 plus, because of the slow enrollment, the trial was stopped, and basically showed that they have initial was the 2-year composite endpoint of the primary, which is the death, MI and TVR, or secondary endpoint was the death, MI, stroke and any revascularization. So, basically showed that at 1 year, at 2 years, it was 11% in the PCI group versus 7.9% in the CABG group. So, clearly the CABG was 3% superior, but it did not make in the non-inferior, the PCI still remained non-inferior, and of course, you can see the curves continue to diverge. Now, if you take the individual endpoints, and that is very reassuring, that you see the difference in the death, not there, MI yes slightly higher with the PCI group, and the stroke was lower with the PCI group, and so. So, clearly it seems to be that whatever the landscape was, that the drug-eluting stent has a higher mortality, no longer true as based on the best trial. Now, we go to the second publication by Sripal Bangalore from our New York State database, again comparing the everlumus eluting stent with the bypass surgery in a large number of patients, and they have the matched population of about 1800 patients, and you can see the PCI and CABG, PCI in red and the CABG in yellow, 5-year follow up of death, identical, higher MI with the PCI, and of course higher revascularization and lower stroke rate. So, clearly now we are seeing, no, we need to do live. You want to say?
No. Okay, show it.
No, okay, can we go back live for the IVUS?
This is the left main now.
Yeah.
Flush.
Sorry, because I think the IVUS
right
has to be seen.
We can play it.
Okay.
Okay, coming out. Yeah.
You want to comment on it now so that we then start our
was a significant plaque in the ostial LAD and distal left main. Just go back right there. did you want to do the circ? No,
Yeah,
right?
you can do the circ. Yeah, but does not matter. Both of them have
Yeah.
lesion. But you want to just emphasize on that plaque?
Go to, yeah. Start playing the whole thing.
Yeah, right there.
A very
Okay.
significant
This is,
burden.
yeah, that's osteal LAD, we keep coming back. Then if you see,
this is
not
the
a lot
left
of, yeah, left main. So not a lot of calcium. So I think we could just do it with the cutting balloon.
And there is a plaque on both osteal LAD as well as osteal circumflex. So while they are getting ready with the flextome and so, we can go back to our presentation. So I quickly complete now, and that is that clearly in this study of case propensity score matched cohort derived from multi-thousand patients, there are like 30,000+ patients, that 1800 patient with a similar characteristics with the propensity score match showed basically no difference in death, higher MI, lower stroke and higher TVR with the PCI. So clearly the one thing very sure that no longer higher death rate. Now, and these are second part was what about, so they clearly said that in a contemporary clinical practice registry study, the risk of death associated with PCI with everolimus eluting stent was similar to that associated with CABG. And of course, we had a higher MI and so. So then what about in the multi-vessel diabetic patient from the same data set, they compared EES versus CABG in the diabetic patients, and you can see here the two findings. One, in the short term outcome, actually the PCI was having a lower death rate. You see the p-value of 0.04, hazard ratio 0.56 in favor of our everolimus eluting stent, and of course we still had higher MI and have a lower stroke rate. So clearly in the short run, in a diabetic patient, we have a lower mortality and lower stroke rate and of course higher MI. Now once you take a long term, again no difference in death, higher myocardial infarction, lower stroke rate and higher TVR. So similar message from all three trials. At present, that there is no difference in death, there is a lower stroke rate with the PCI, but higher MI and higher repeat revascularization. So basically that really puts it together that at present patient with diabetes and multivessel disease, that EES stroke when the lower upfront risk of death and stroke when compared to a bypass surgery. However, long term EES was associated with similar risk of death, higher MI and higher revascularization. So clearly we have totally different findings, and that is what we see in our real life. So with that note, I'll finish our discussion. Of course, the Excel trial, which is going to talk about the left main in 1800 patients versus EES, will be presented. They think about next ACC of 2016. Okay, Anu, tell us what's happening now.
So we wired, we did the IVUS, but the question is same. This is where we are, distal left main, osteal LAD and osteal circ. I think this is a good view, which is a caudal view where we see both the lesion. I think the plan should be cutting balloon of both the branches and what is the stenting strategy that we need to have.
Excellent.
Double stent, or do we think we do 2 stents?
Right. I think that should form the major teaching point here. Which strategy would you like to use here? Samin, going back into your peri-procedural MI and the different ways to decrease it, you think cangrelor could play an important role?
Oh, absolutely. Particularly the patients who have not been preloaded, absolutely. That actually have been shown, which actually, you know, I should have put down that also. It's not just antiplatelet therapy, but cangrelor will play clearly a role in patients with acute syndrome and not enough time of your pre-procedural antiplatelet therapy. So that yes, cangrelor will be, and you know it's available now.
Yes.
Actually, I'm going to use on one patient who needs a patient has a frequent CAD. I had done like 20 interventions on him, and he needs a back surgery. Yeah, and about 6 years ago, when we stopped it for one back surgery, he developed MI. So this my goal is I'll bring the patient, we decrease the agent, take him off the cangrelor, and then start him on cangrelor till he had a surgery.
Excellent.
Okay, so we have a trio cutting balloon, which is a flextome, and this is where it is. We are just at the distal left main and osteal LAD. Now, We do have a temporary pacemaker here only because the baseline heart rate is in the 40s. His EDP was just about 8. We gave a lot of hydration with the creatinine was 1.2. Now his blood pressure is just about 90 or so. We had to give him some neo. So whenever you're doing intervention, left main, ostial LAD, so make sure your blood pressure is good in 3 digits. So we did have to give some neosynephrine. Okay, now. So what we did the cutting balloon, then we took the balloon back in the guide and went back in, did 2 dilations.
So only for the LAD yet?
Only LAD, now we will do circumflex also. And knowing that the left main, this distal left main can accommodate 2 stents, otherwise there is no disease distally, nothing wrong with the approach of 2 stent, which would be a V stent technique.
Yeah, this kind, once you have a large plaque burden in the side branch and is a large vessel, as our algorithm has shown in the past, that's the case, you should go with a 2 stent approach, where the planned 2 stent, not as a bailout. Because let's put this way, you put a stent in the left main to LAD, patient has a ostial circ disease. What are you going to do? Not by cutting balloon or only, you are going to put a stent anyway. So therefore, you need to treat this as a patient who have a large vessel and significant disease in the side branch. I mean, so that it has to be a 2 stent approach.
This is the same trio?
Same
Trio. Down.
And second time you have to go a little slower inflation, and again pull back in the guide and go back again, hopefully cut in the different direction. Good. No, pull back. Yeah.
The reason we pull back and go back in is that the blade orientation will change when you pull back, go back in.
Without doing any rotational movement to it or something? Okay. Anu, quick question for you. It's an important point. Now in the CANARY trial, now we've outlined that OCT may be the right or the better modality to do it. The reason there was no benefit from the distal protection devices, is it more technique related or device related or both?
No, the question is that the periprocedural MI that happened with this patients, right? What kind of embolization did they have? Was it micro or macro? With the filter, what we were not able to capture any, probably micro.
That's it, and that is the key. So your lipid or your platelet aggregation, that cannot be taken care by the filter, and it's consistent with every filter trials in the past, that in the native vessel filters do not help because of the branches. So no matter where you put, it will go to the branches and still will cause myocardial infarction.
So going back to the point, remember the first paragraph of periprocedural MI, what are the causes? That one, you have procedure related, which is visual, that is side branch closure, dissection, or macro embolization, which is slow flow and all these things. When it's micro, you don't see anything that happened, it's only post procedure that you see an enzyme elevation. And that is where I think that if you have done imaging modality and you know it is a high risk plaque based on the characteristics, that's where we as interventionists, is there something that we can do to prevent it once you have seen it and patient is already on the table.
Yeah.
So Samin, the question I'm sure which is now going to emerge here about the case is, what stenting technique, why V and why not SKS?
Yeah, I mean same.
It
SKS
says,
is the same. The V basically is the short V. Short SKS is a V. That's one. So that 2 millimeter.
2 millimeter. If it's 2 millimeter carina, it's a V. But here we may end up with a SKS. If you see there,
right, it
we
looks
probably
to be more
will be a 4 millimeter.
Yeah.
Right.
Yeah, 4-5 millimeter. Yeah, that
will
still
be
remains.
SKS.
The other question is, what people will say that why not DK crush, which has been shown, or a culotte. So those are the different or mini crush. But I think all techniques are good as long as you do it correctly, step by step fashion. So I think in this case, we need to have a 2 long stents, right? The stent in the circumflex, we have to take care until that angle. So you take a 3-0, the 28 or 33.
I think you want to put a 3023 to the circ.
Okay.
And probably a 30.
Also 23. To
23.
We
Both.
had to take the
Two 3Os.
2 3Os. Bring 2 3Os. Zions. Yeah. Yeah.
Now, all the technique that were mentioned is the right technique to be done, but what is the quick technique is probably the V and SKS.
Go with, and always try to go into the more angulated vessel first, which is the circumflex.
So, Anu, based on the two papers you presented today, you think it is almost convincing now that OCT is the best modality for predicting periprocedural event, and
Yes.
what does that do to near?
No, I mean what I meant is the same. That's why we gave that almost like an algorithm that
Right.
if you have done this, you cannot do two imaging in one patient to predict. So if you have done IVUS, there is the predictors which would be the plaque burden as well as your CSA. If you don't have, if you have done NEARS, you will have your LCBI, because IVUS and NEARS comes with the one catheter if you have used that modality. If you have not used that modality, if you have used a simple IVUS modality, then the IVUS that we just did would be just the plaque burden that we are looking at. But of all, if you have had, I think probably OCT will be better, since it will give you the cap thickness as well as the lipid arc, which we did not mention, but that is probably equivalent to your LCBI.
Patient tolerating well now?
Actually is
Little restless. I think part of that little sedation, somebody with a cirrhosis, not working good with his body.
So same, you bring your two dots and try to pull back.
Maybe okay.
Okay, now this is which is
Slightly not aligned there, the dots.
I'm bringing back the LED, not aligned.
This was a 7 French system?
Yeah, this is 7 French. This is circ,
Yeah.
right? LED is not coming back.
Pull back a little bit. Yeah. We need to quickly finish.
Okay,
Yeah.
good. Ready?
Take a select.
What do you think?
So the-
Go back in a little bit with the circ.
Just go 1 millimeter.
So the
Wait,
first
wait, wait.
important
Yeah,
step
good,
to
good,
have
good.
the proximal stent markers absolutely
yeah.
aligned.
Okay.
Okay, go up.
Okay. We are going up both.
Both same time, Vicky, some neo.
12 atmosphere.
And you see there, guide is out of the proximal down, ostium. Now one of you go up,
Yep.
12, 14.
Yeah. No. Okay. Go. Yeah.
Despite the cutting, okay.
You can go
14.
16. Yeah.
Good. So this will tell us that the LED stent is nicely expanded.
Right.
The
Go. Go
So
up
now the LED balloon remains there, and then we go with the circ. Same
Again,
thing.
14, 16
Yeah, this one
atmospheres.
14. Expanded 14, which is good.
Yeah, down. Now you see that looks like one of the dot has moved, but
No,
not
but
to
that is
worry.
just because
Right.
of
Yeah.
this. Just because the one
Try
is
not to
deflated,
change
other one is
anything.
inflated. Yeah. I will go back again. Again at
Still
12
moved.
atmosphere.
Yeah.
The fourth simultaneous inflation as well as simultaneous deflation.
You go less. Who is
Yeah.
circ? You.
Okay,
Less. You go
10,
higher.
you go 14. Yeah. So 10 of the circ and 14 of the LED and negative.
Down.
Simultaneous deflation. Good.
This we may have a
And we'll
problem.
try to do IVUS. Make sure you close, clear that.
So three definite steps to it.
Yes.
No, I pulled took both the balloons out at the same time. Now I think you should try to take it individually. Ready? You can inject.
May have to post that.
Probably the circ
Looks
requires
good.
a little.
Don't do anything.
Okay. Let's see. The question is,
should
do you
not.
want to do the IVUS and or just dilate? Let's take a better picture with the balloon out and then decide whether you need to post dilate, which in SKS or V requires in about low teens and 10-15% of cases only.
That you would do with the non-compliant balloon
Non-compliant
individually.
balloon? Yeah. Yeah.
Yeah, I don't think so.
Okay.
Looks good.
Sydney. This actually
Looks
very
good.
good.
Should not touch it.
Do the IVUS quickly. Go. So we do the IVUS this time. Do IVUS in the circ.
Okay.
Little downstream on the circumflex needs a
Distal
little
edge.
balloon there.
Yeah, I saw that.
Yeah.
Look,
No,
we're
no,
going
I
to
think,
do IVUS. Let's see.
No, I meant right at the
Yeah, at the-
distal end of the stent.
Yeah, exactly. I see that also.
Ay, ay, ay. This may be a problem.
Anu, forgot to ask you what were the wires you had used
We have
initially.
fielder in the circ and run through in the LED.
Yeah.
All right.
Okay, good. That's here. Yeah.
Stay there.
All right.
Okay. Pull back, Pablo.
Show the IVUS. Good. Yeah.
Good.
Good.
So this is the distal edge of the
This
stent.
The distal has looked okay,
Yeah.
and it's coming. No, there is a plaque there.
Yeah.
Yeah.
Got shifted.
A little vertical displacement, exactly what Samir you pointed out. The plaque has moved maybe distally.
Right.
No.
A little bit.
Look,
yeah.
look.
Well,
I think we placed the stent on the plaque. See that?
That's why I wanted 28 there. And see
Ah.
these two dumbbells,
Yeah.
very nicely expanded, two dumbbells attached to the vessel wall. If you want to put a short stent there, it's fine, otherwise we will complete this.
You want to?
Okay, no? You want to decide? Good. How-
Done.
Okay, do one more caudal view.
so based on this, you want to leave the circle on,
There's a little
and
bit of
possibly the
Yeah, question is I think let's take another angiographic picture that then make a decision. Just 1 second, I'm good to the floor. Yeah, good. You want to give a little nitro?
right.
Okay, go. I think a little translucency
Where?
in the distal edge of the
Yeah, the distal edge
circ.
is
Because reason is the circ stent has landed in a mild plaque.
Yeah.
That's the issue.
small 8 millimeter.
Yeah, I think just complete it. That's
Okay.
better.
8
In
millimeter.
this particular
Trio.
case, because we don't know his
3O.
antiplatelet therapy. Yeah. Or 2.7. Huh?
275.
3O should be
3O.
fine. 3O
3O.
should be
308.
It will be okay.
Yeah, otherwise looks very nice.
Plavix, right?
But see, this is the classical. This is the advantage of the SKS technique. No need to recross. Don't worry about post dilatations and so on and so forth.
8. They have 8 or no?
No, he's bringing
8 is a
yeah.
issue at length.
So 28. Yeah.
Yeah.
SSR 28. Good. Actually, this is a kind of similar deja vu. I don't know whether we may have some people from
look, you
Hyderabad.
covered
No,
it. You
it is
covered
not.
it.
Come at edge. That in Hyderabad
plaque
exactly was the same case. Distal left main, we did a cutting balloon and put 2 stents. And I wanted in the LAD longer stent, but that stent was not available. So we put short. And same, distal edge was little dissection or little plaque. So I had to put another 8 millimeter through that barrel. So at least was good point to show that stents usually go through this. These barrels is not a problem.
Why can you teach these people?
So same to me what happened just on July 12th in Hyderabad. Same thing here. Okay.
Too far?
Okay, go.
Go up.
Okay.
And with that note, we just
Wait,
take a last
done.
picture.
How
Yeah,
high?
12, 14.
Down. No, no, no. Don't go that high.
Yeah. Overlap a little more. And here is
Okay,
okay, but
14.
if you need to post dilate, you have to put a balloon in both the limbs. Otherwise, we know that you are going to crush it.
Okay, down. He got Plavix, right?
Yeah. good, good. He has low platelets anyway. Yeah, 92,000, so that with cirrhosis and so. Yeah.
So, how would you long term follow this patient?
Yeah, I think the same clinically we learned, and there is no additional disease, so that usually once there is additional disease, we bring them back for follow-up angiogram. But if nothing, the clinical follow-up and do a stress test at 1 year, and just if anything needed, then only you take care.
Looks wonderful there.
All right. So with that note, we go to our presentation. We complete it. That is take-home messages from today's that imaging for PMI prediction and newer DES versus the slides. Some audio, yeah, good. So imaging for PMI prediction, periprocedural myocardial infarction and newer DES versus CABG and multivessel CAD. Multimodality invasive imaging can identify lesions likely to be associated with periprocedural MI. OCT defined fibrous cap thickness followed by LCBI by nears and plaque volume by IVUS are important predictors. The use of strong antiplatelet therapy, including IV cangrelor, GPI, statin and beta blockers may be recommended to reduce PMI in these risk-prone plaques on multimodality imaging. Filter distal protection device has no role. Recent randomized and registry data have shown that long-term death is not higher with newer DES, particularly EES type versus CABG and multivessel CAD, including diabetics. Both MI and TVR is higher still with newer DES, while stroke remains higher after CABG. So we go to 3 quick questions. Following are the predictors of periprocedural MI on imaging except high LCBI, lower lumen cross-sectional area, thin cap on OCT, lower plaque burden and necrotic core on VH. Based on the multimodality imaging, which plaque characteristic has the highest odd ratio for periprocedural MI? Cap thickness on OCT, LCBI on nears, plaque volume on IVUS, lumen CSA on IVUS or necrotic core on virtual histology. Third question. In recent years, trials of newer DES versus CABG for multivessel CAD have shown the following, except higher TVR with PCI, higher CVA with CABG, lower death rate with CABG, higher MI with PCI and higher death MI and TVR with PCI. So clearly this has been a phenomenal case and experience, and hopefully our viewers audience liked it. They should watch it and ask the questions.
Look, a wonderfully performed, elegant case, done so nicely, didn't even look such a complex and tricky case, and excellent review of some of the imaging modalities. Anu, final word from you?
Usually I talk on technical tips.
Right.
The technical tips, I think just to go, go with the case. I think preparation of this particular case was very important, that angiographically we knew that there was no calcium. So like you had initially predicted, there was no need for any kind of atherectomy, but instead you definitely need what is called as atherotomy, since it is osteal lesion, which is a distal left main and osteal LAD, osteal circ. If you had not done atherotomy, if you see the final picture, you will have osteal LAD or osteal circ under expanded stent, and all the various technique of stenting have been discussed, which could be a V stenting. Otherwise you could do stent across to the LAD and then just a cutting balloon of the side branch of the circ versus culotte versus DK crush. But what we showed here is double stenting, and it could be done safely and faster as we shown. And many people don't believe in this kind of V stenting or SKS stenting, since you have 2 barrels in the left main. But what we just showed you, that despite 2 barrel, you can go through that 2 barrels. We showed the IVUS post procedure, as well as we did a stent through the barrel. So if they come back and if you have a new lesion distally, as long as you have the wire in the true lumen of the vessel, which could be that suppose you wire it and you have a problem in advancing any device, take the wire back and rewire it, and always first you have to do is try to go with the deflated balloon, and you can always deliver a device distal to the stent, and that has been shown here. And just going back to the imaging part, I think we have shown based on the 2 publication and our experience here in Mount Sinai, that if you have all the imaging modalities, one image of the imaging modality, if you want to pick one, OCT probably is better if you have it to predict periprocedural MI. If you do not have it, then you can use the IVUS, the predictors for IVUS also. But once you predict, we are talking about stable patients, that it is very important as interventionalists that you have to do everything to prevent the microembolization, to prevent this periprocedural MI, and that I think the best of all the modalities would be to give stronger antiplatelet agent.
Okay.
Excellent summary, Anu. I think the simplicity of the approach to me was the overriding and the educational component. Congratulations again, wonderfully performed procedure, excellent publications, and with that we will conclude today's session and see you next session number 74, which is going to be on August the 18th.
All right.